wiser, right?
Okay, thank you, Prof. Can everyone see my screen right now? Can
you share the screen? Thanks.
Okay. Okay. Can everyone see the screen?
Yes, okay. Come, let's proceed.
Okay. So first of all, let me do a brief introduction of the patient. The patient we have today is Madam F.A. She is a 37 years old lady, currently 24 weeks pregnant. She was diagnosed with SLE back in 2013 with underlying musculoskeletal autoimmune hemolytic anemia as well as lupus nephritis manifestations. Right. She also had pulmonary TB back in 2010, in which she has completed treatment and she is fully vaccinated for her COVID. So she first presented to the PAC complaining of fever, cough, and runny nose, in which she had a positive oronasal swab from GP, which is positive for influenza A. Following that, she was admitted into the obstetrics and gynecology ward for 1 day, and she was started on Tamiflu for 5 days. However, she came back to our ED again 5 days later, complaining of cough for 3 days, and this time with hemoptysis for 1 day. She had 2 episodes of hemoptysis at home and 1 episode in ED, and she described the hemoptysis as whitish sputum with blood streak. So upon arrival to ED, on examination, patient appears to be pale, and she had a respiratory rate of 20 breaths per minute with a blood pressure of 113/73, heart rate of 108 beats per minute, sinus rhythm, afebrile. Examination-wise, her lungs had reduced breath sound over the right upper zone, whereas the other systems are unremarkable. Sorry.
So maybe you can share with us what other history you want to know.
Okay, so thank you, Prof. So in terms of next management, first of all, I would like to start off by taking more history from the patient, namely the amount and frequency of the hemoptysis to assess the severity of the hemoptysis. And I would also like to ask about other symptoms such as any constitutional symptoms suggestive of PTB reactivation, such as loss of weight, loss of appetite, any contact history with TB patients recently, any consumption of traditional medications or supplements, any history of pulmonary embolism in the past, and also any symptoms suggestive of antiphospholipid symptoms such as stroke, TIA, DVT, miscarriages, or skin rashes. And also, I would like to ask her about her list of medications as well as her compliance to medications.
Okay, so I think we'll target the history first. So you're right to ask about the amount and frequency of hemoptysis. So she had about 50 mils total over 24 hours. Right? Do you know any way of, is there a reason why you want to ask about the amount of hemoptysis?
Yes, basically, when I ask about the amount and frequency of hemoptysis, it's to assess the severity of the hemoptysis. But currently, there are no consensus on the classification of hemoptysis. But I think the most important part is that we need to assess the vital sign as well as the hemodynamic stability of the patients.
Good. So there's no consensus, you're right. Usually some of them take up to 600 mils over 24 hours, right? In terms of amount of blood that is coughed out. So, okay, I think hemoptysis is a sign of many different diseases. From here, I see that you are trying to rule out TB. So yes, she doesn't have any loss of weight, loss of appetite. There's no contact with TB and no traditional medication. PE, probably not such a common thing, but you are thinking in terms of SLE and whether she's actually got a vasculitic thing. So she doesn't have any history of PE in the past or any symptoms to suggest antiphospholipid. List of medications, yeah, she's on some immunosuppressant. She can't remember, but she said it's that. So maybe I'll go to the next, before that, the physical examination, right? So I think she actually had, what was given to you was some decreased breath sounds in the right upper zone. Isn't that right?
Yes, Prof. Yes.
Yeah. And investigations, let's move on to the next slide, see the investigations.
Right. So here are some of the investigations.
So maybe like to interpret from here, can you rule out certain things or rule in certain things?
Yes, Prof. Right. So from the investigations that we can see here, most of the investigations are normal, except for a few in which the white cell is raised. It's 11.5. And at the same time, the CRP is raised also from the previous reading, which was 2.3, and the current reading is 10.1, 10.01. D-dimer is slightly raised, is 1.34. And they had a arterial blood gas on room air, where it showed reduced PO2 of 67.6, suggestive of type 1 respiratory failure. So culture-wise, there is a coagulase negative staphylococcus seen in the blood CNS, but the comment there was that it's a normal skin flora. So based on the investigation that we have here, it is suggestive that the patient is having an infection of some sorts, in which we need to investigate further.
Okay, so what is the next logical investigation you want to ask? Bearing in mind that
At this yes,
bearing in
at this
mind that I'm a chest
sorry.
physician asking you, right? So what are
Yes.
the
Right. So at this point, I would like to ask for a chest X-ray for the
Oh, well
patient.
done. Okay, we will show you the chest X-ray. Right.
All right. Thank you, Prof.
Okay, so you have what you asked for. Take a minute to look at it, bearing in mind what your differential diagnosis is and the clinical findings. So my first question to you would be, does the chest X-ray fit the clinical findings that were presented to you in your in the earlier slide that you showed?
Yes, Prof. The chest X-ray, we can see from the chest X-ray here, it looks like the airway is slightly deviated to the left side, and then there is an opacity seen on the right upper zone of the lungs. Other than that, most of the other findings are quite normal. So based on this, I would think that the patient, I think these are my diagnoses, but I think the two most important diagnoses here is that the patient is likely to have a pneumonia in pregnancy or a reactivation of a pulmonary TB, given that she had history of TB before and she is immunocompromised from the treatments of the SLE.
Okay, all right. So here the provisional diagnosis is fairly acceptable, the pneumonia in pregnancy, and I'm happy to see that you actually put reactivation of TB and aspergillosis. So I think it's important to recognize that when you have someone with hemoptysis, the commonly recognized things that you should rule out would be infections, inflammatory airways, and actually also cancer, right? Okay, right.
Yes,
Okay, shall
Prof.
we move on to the next slide? Okay, so I'll probably just tell you a bit of the progress of the patient. She subsequently became more tachypneic, more tachycardic, and she developed another episode of hemoptysis, and she went asystole after a separate, an additional episode of hemoptysis. So she had return of spontaneous circulation after 2 cycles of CPR. She was intubated, resuscitated, and transferred to ICU. So at this point, Dr. Ng, probably want to ask you, what is your next step of management?
At this point, aside from the ICU stay, we need to do further investigation for the patients. We to find out what is the exact cause of the infection and how, and as well as the hemoptysis. But at this stage, I would like to get obstetrics and gynecology involved as well. To I would like to involve the multidisciplinary team to manage the patient better in this case. So I would like to refer to respiratory, obstetrics and gynecology, as
So
well as the intensivist. Yeah.
of all of it, in order of priority, who would you refer to first in this stage, at this stage?
Oh, yes. So at this stage, I would like to get a further investigation based on the chest X-ray, because the chest X-ray has shown opacity on the right upper zone. So I think the patient needs a CT scan of the thorax. And in this case, I would like to order a CT pulmonary artery, because the patient had raised D-dimer. So we need to rule out any possibility of pulmonary embolism.
Okay, all right, let's move on to the next slide. Okay, so so you're right, the patient actually underwent a few investigations, of which one of it includes the CT pulmonary artery. So I'll probably now like to invite Associate Professor Dr. Soraya, consultant radiologist, to bring us through the CT pulmonary artery.
Okay. Okay, thank you. Yeah, let me share the screen. So my screen would be this one. Okay. Can you see my screen now?
Yeah,
Yes,
can you
Prof.
put on slideshow mode,
Okay,
please?
slideshow.
Right.
Yeah. Okay. Right. Okay. Now, how do I do it? Okay. All right. Okay. Okay. Before I show you the CTPA, I just want to show you again your chest X-ray just now. You're right. You have that opacity at the right apex. And then moving on. Okay. Wait. Next one. Okay, I just want to just bring you and focus a little bit at the apical region there. If you can see, actually you have that thing there where you have that air crescent sign, the lucency surrounding that opacity that we saw earlier. Okay, so that's what we call the air crescent sign. Okay, that brings me to the CT pulmonary angiogram. Okay, that was requested by the cardio thoracic surgery. So Juin Yi, maybe you want to interpret for me?
Okay, thank you, Prof. So from what we can see here, these are the axial cuts of the CT pulmonary angiogram for the patient, and this is in the mediastinal view. We can see that from the upper two images, we can see that the pulmonary trunks, there are no filling defect within the pulmonary trunks. So that is not suggestive of pulmonary embolism. So there are no pulmonary embolism involving the pulmonary trunks. And on the lower two images, we can see that on the left lower image, there is a mass seen within the right thoracic, within the right lung region of the patient, and it seems to be encased by a thick wall, that mass.
All right. Okay. So next slide, I show you in this coronal section. So what can you make of this?
Right. So this in this coronal view of the same patient, again we can see there is a mass on the right upper zone of the lung, and it's more at the apical region. So yes, again we are seeing the same mass in a different cut.
Okay. All right. So to complete that, I give you another two views.
Okay, so from the lung window in the axial cut as well as the coronal cut, we can again we can see the now the mass is more defined. There seems to be a mass encased by a thick wall surrounding the mass. So from the scan itself, I think it's likely to be a fungal ball, which is also known as aspergilloma.
Okay. All right. So you're right. If you want to, I just want to highlight there. So this is actually called response to our chest X-ray. Okay. So the lucency that we saw, the one that is surrounding the fungal ball, is this one. So this is actually a cavity with an intracavitary mass, which is the aspergilloma. Okay, it's a very thick wall in the apical region of the right lung. Okay, so you can see that. And if I
Soraya, your line is you're breaking up.
that it to let you know that in the right middle and segment. Oh, that better? Can you hear?
Slightly
Tak
better.
dengar. Okay, can you hear me? Okay. So on the coronal view, there is also just to show you that there is no filling defect in all the pulmonary arteries bilaterally. So that confirms that there is and there I can unshare the screen again. Stop share. Okay.
All right, thank you.
Right.
So I think to summarize what Prof. Soraya said, there is actually a fungal ball, suggestive aspergilloma, and there is also no filling defect, right? So, Juin Yi, diagnosis now, and anything else you want to do?
Right. At this point, I think we need to revise our diagnosis in the case that because there is an aspergilloma from the seen from the CT scan. So my provisional diagnosis will be invasive aspergillosis with aspergilloma seen in the lung. And from here on, I would like to ask for further investigations regarding this. That will be referral to respiratory team and bronchoscopy. And from the bronchoscopy, would like to, sorry?
Can you share your slides?
Yes, sure.
So you mentioned bronchoscopy. I think that's important because I think evaluation of hemoptysis should include a conventional chest X-ray, a CECT, and also a bronchoscopy. There are many reasons for bronch. One of it is actually occasionally hemostasis can be achieved bronchoscopically if you actually see the area of bleeding, right? The additional things that bronch can do would be to localize the bleeding, right or left lung, what lobe, and then the surgeons can actually remove that lobe, right? Cause of bleeding. Sometimes we can also harvest material, right? Meaning you want microbe, cytology, histology, so all of that. So I would like to know, so we actually, I think you referred to us, we actually wrong for two things. One would be for the hemoptysis. The other one is actually to get samples, right? Can you show your next slide?
Okay.
Okay, all right. So these are the investigations. I'll save you the bother. I put it in red. So can you interpret and tell me what is your diagnosis now?
Okay, thank you, Prof. So we can see from the bronchoscopy investigations here, the bronchoalveolar lavage aspergillus is positive, and the culture sensitivity came back as Pseudomonas aeruginosa, sensitive to ceftazidime, and cytology is unremarkable, and it's negative for SAFAS bacilli and TB PCR. TB CNS is pending, and the fungal CNS is negative as well. So from the investigation, it confirms the diagnosis of invasive aspergillosis with the presence of aspergilloma within the right apex.
Okay, so I think confirms the diagnosis is a little bit of a stretch, but for the moment, yes, I would agree that's invasive aspergillosis. Along the way, we will see what can be more confirmatory. Can you go on to your next slide?
Okay, Prof.
Okay, so what now?
So now that we have got all these investigations, first of all, I would like to arrange an MDT for this patient because it's a complex case, and we would definitely need aids from other departments such as respiratory unit, obstetrics and gynecology units, radiology, and the intensivist.
What about
sorry?
about treatment of the?
Yes, treatment-wise, I would like to stop the anti-TB for the patient. And also at the same time, I would like to start the patient on antifungal as well as antibiotics based on the culture and sensitivity.
Do you know of any antifungal that you would want to give? Just name me one.
Yeah, one of them will be amphotericin B.
Fair, all right, fair answer. Okay, can you go on to the next slide?
Okay.
Okay, so this has been done. I think we move on to the next slide.
Okay.
So I think, right. So probably just want to share with you that we actually had another, because of the recurrent hemoptysis, right? So there is a role for bronchial artery embolization because actually theoretically it's actually a first line treatment of hemorrhage if you can identify that's from the periphery. And indications for performing is actually for massive hemoptysis or recurrent hemoptysis, and in this patient is indicated. It's usually successful in about like 75 to 98% of the thing. If it fails, then we do something else, right? So bronchial artery embolization done, and these are the findings. Okay, what would you do next? That one settled already, so what would you do?
Okay, so at this point, I would like to refer to obstetrics and gynecology as well for the assessment of the fetal well-being, as well as to discuss with them on any concerns about the radiation, because we have done a CT scan for the patient. Any concerns about radiation exposure to the fetus, as well as most importantly, the timing of the delivery. When can we safely deliver the baby in this case?
Okay, all right. So again, can I just ask you, the hemoptysis is likely due to what? Can you tell me?
The hemoptysis is likely due to invasion of the aspergillus into the blood vessels in the lungs or the bronchial vessels.
Okay, so it's likely aspergillus related. Okay, next slide. So I think from here on, I would like to pass over to my co-chair for today, Mr. Hisham, to bring us to the remaining journey of this patient. Thank you.
All right, thank you so much, Associate Professor Andrea. Can you hear me?
Yes,
Yeah.
yes, Mr. Hisham.
Well, I suppose we have discussed about the history, physical examination, a few investigation, and also some of the planned management for this patient. For the interest of everybody, I would like to introduce Dr. Juin Yi. He is the cardiothoracic surgery fellow who's now in the parallel program in cardiothoracic surgery, joined with KKM, MAT-CVS, and Royal College of Edinburgh. So he is one of a fellow over here and who is doing attachment for 1 year. So Dr. Juin Yi, we have come to the point that we know the diagnosis already. All right, you have gathered everybody to help to manage this patient, including the ONG counterpart and also the respiratory team, and also a few in intensivists as well. We have called up our colleague in ONG for help, and we like to call upon Professor Dr. Rohana, our ONG obstetricians, to just brief about what had been done and what is our concern for this patient. To you, Dr. Rohana.
Yeah, Assalamualaikum and good morning. Thank you, Mr. Hisham. I'm going to address the concern from Dr. Ng. I think you mentioned just now that in regards to the radiological procedures that she had gone through and what are the risks to the developing fetus, and also in regards to the timing of delivery. So next slide, please. So in terms of safety of radiological procedures in pregnancy, of course, any radiation can have exposure to the fetus. It can end up with a pregnancy loss, malformation during organogenesis especially, and it is dependent on the radiation dose. It is also can be carcinogenic. It can develop at any level of radiation exposure, and it's also dose dependent. Next slide, please. So in general, the recommended total fetal exposure should be less than 50 milligray, and in the range of 50 to 100 milligray is actually safe. This is showing you the comparison of each radiological procedure. If you go for a plain film radiation, and that is the level of exposure. CT scan about 50 milligray. MRI is actually quite safe. It uses magnetic field, so there is no involvement of ionizing radiation. And so is ultrasound, which uses sound wave and no ionizing radiation. Next slide, please. So for this patient, in view of background history and a problem and the current acute problem, so we were thinking whether she's going to have another bout of massive pulmonary hemorrhage, which may end up with having to deliver her earlier. But if she remains stable, then we thought that it's quite decent to plan for a delivery at around 28 weeks, right? So of course, with the pregnancy on still there, that will limit a lot of management on your side, the cardiothoracic surgery side, and also the respiratory side. So in preparation for a preterm delivery, We shall give her antenatal corticosteroid for fetal lung maturity and also magnesium sulfate infusion for the fetal neuroprotection. And of course, we're going to talk to our NICU colleague in preparation to book a ventilator for the fetus. And of course, in this case, our priority is always the mother. So next slide. If we are going to get to deliver her at around 28 weeks, our most anticipated problem during the cesarean section will be that the lower segment is not well formed. And of course, this is also associated with the type of uterine incision. And the most problematic thing that we have to anticipate is delivery of the small fetus. We will try to avoid trauma to the fetus by delivering the fetus in encore delivery. That means the fetus is an intact sac when we deliver the fetus. I think that's all on my side. Thank you.
All right, thank you, Prof. Rohana. Thank you for the enlightening about this patient. All right, okay, let me tell you about the progress of the patient. The progress of the patient that we noted that the bleeding recur. Patient have hemoptysis and bleeding inside the ET tube during intubation. And that point of moment, it was 28 weeks of pregnancy. Sorry, 26 weeks of pregnancy. This has come to about that the embolization failed. And we try to repeat another bronchoscopy. If you can see the bleeder, we can see only clots, and inside the airway. So we are stuck at 28 weeks, 26 weeks pregnancy, recur bleeding. Next slide. So what do we know so far? 37 years old pregnant lady, immunocompromised because of SLE with long-standing steroid. Currently at 26 pregnancy, diagnosed with invasive aspergillosis and aspergilloma at the right upper lobe of the lungs, with hemoptysis despite of embolization, recurrent hemoptysis with some hemodynamic instability. We have organized MDT, and Dr. Rohana had input that if we can prolong delay the surgery or any surgical intervention to the near term or to 28 weeks as the earliest, but we are now in 26 weeks. All right, and we can't delay the pregnancy anymore because this is hemodynamically compromised. So we have to go on for lower segment cesarean section, and after delivering the baby, then we have to quickly address the invasive aspergillosis. All right, back to you, Dr. Ng. If we have delivered the baby, as soon as possible, we have delivered the baby, and now we have to save the mother, and we have to do an operation because of other modality had failed. What is your pre-operative preparation for this ongoing surgery, and what are you going to anticipate during the surgery?
Okay, thank you, Mr. Isham. So the surgery that this patient most likely need is a lobectomy, KIV pneumonectomy. Based on the CT scan, she most likely needs a right upper lobectomy. So in regards to that, ideally we would like to request for a lung function test for a patient, but in this case, the patient is intubated, so lung function test is not feasible, and it's an emergency operation. So we will not proceed with the lung function test in this particular case. However, we would like to discuss with the family and the patient, if possible, regarding what is the current diagnosis, what is the progress, what do we want to do with, what do we plan to do for her in terms of surgery, and what are the risks, and at the same time, we would like to get a consent from the patient as well as the family members for the surgery. In terms of the surgery, we would like to anticipate bleeding as well intraoperatively. So before the operation, we need to talk to blood bank to standby blood products for the patient, such as PEG cell, platelet, cryoprecipitate, as well as fresh frozen plasma, and also to optimize the preoperative antibiotics as well as antifungals for the patient.
Can I ask, is this going to be a very high-risk surgery? Why?
Yes, Mr. Isham, I think this is a high-risk surgery because number one, the patient has ongoing bleeding. and she is intubated and is an emergency surgery, so it will be higher risk given that we have a shorter time frame to optimize the patient.
Yes, it's going to be a high-risk surgery, high-risk consent, if possible, from the family members as well. Not to forget that this patient is immunocompromised. All right, any surgery can go anywhere, can go sour, especially in immunocompromised patient and long-term corticosteroid. Bleeding is a problem. As correctly said, that bleeding is going to be a problem for this patient. All right.
Yes.
Okay. Next slide, please. So we had done the surgery. I would like to call upon Prof. Dato Dr. Hairul Faizi Harun, our consultant cardiothoracic surgeon, to tell a bit about what we have done for this patient. To you, Dato.
Assalamualaikum and thank you, Mr. Hisham. So I would like to start off with the timing of surgery, right? As we all know, once the patient has been diagnosed, of course, from the signs and symptoms and confirmatory with the investigations, which include chest X-ray, CT scan, and not to forget histopathological examination. So most of the time, this patient is, the procedure is performed electively, maybe 2 weeks or 4 weeks from the diagnosis. It all depends. Once the bleeding occurs, so we need to do the patient as emergency. However, for this patient, it's a bit more special, not just because of the bleeding itself. This patient is pregnant. So as mentioned before by our colleague, so we need to delay as much as possible until the baby fully term. And again, due to immunocompromise, we need to cover this patient with antibiotic, and also not to forget the antifungal medications. And also we need to cover the patient, due to the malnourished condition of the patient due to chronic infection from the aspergillosis. So we need to properly provide the nutrition to the patient prior to the surgery as much as we can. Next slide, please. So what are the approach for this patient? So we have two approach basically. One would be video-assisted thoracoscopic surgery, which is known as VATS, and another one would be open thoracotomy. So I have a bit of illustration there. So as VATS, we have it's either uniport or single port, which is usually 3 centimeter to 3.5 centimeter in length. And also it can be performed multi-port, 2 port, 3 ports, or even 4 ports, depending on the type of surgery being performed to the patient. Next. So these are the incision for the open thoracotomy. The example, you can see there's a midline sternotomy incision, it's a pacemaker incision, there are thoracotomy incision, be it posterolateral, lateral, or anterolateral thoracotomy, and there's another one, axillary thoracotomy, for different type of surgery. Next. So what are the advantages between VATS and open? So, of course, as we all know, VATS can provide a better cosmetic, better wound healing, less infection. It gives you a shorter hospital stay, and of course, less pain to the patient, and a better view during the surgery. However, disadvantages of VATS would include for the beginner, for the trainee, initial longer operative time, and also a steep learning curve. Next. For open thoracotomy, so it's suitable actually for the second surgery, or even surgery which dense addition we anticipated because of previous thoracotomy surgery, or even we anticipate because of severe previous chest infection, like in our cases, or when there's a complication that occur during VATS, so we convert from the VATS to open thoracotomy. The disadvantages would be longer hospital stay, infection, limited field of view, and of course pain due to bigger incision. Next. So for this patient, we need to have a special consideration due to immunocompromise, bleeding, and also pregnancy. Next. So I would just like to show how we do for the patient. These are the example. Actually, we couldn't get the proper, permission from the patient except for the last 2 slides. So normally we do two type of incision. Usually we do uniport, single port for lobectomy. But for this patient, due to anticipation of the adhesion, so we perform a multi-port, actually 2 ports. As you can see, there's one incision performed at the 7th intercostal space in between the anterior and mid-axillary line, and another one at the 4th intercostal space in between the mid and posterior axillary line. Next. So just how we do the surgery. So there's a bit of video there, very short video, 4 to 6 seconds. You can see the small wound there, 3 to 3.5 centimeter in diameter, and also the previous chest tube can be seen anterior towards the incision. Next. So these are the findings that we normally see because of aspergilloma, one, or because of previous surgery we performed. You can see dense adhesion from between the lung and the chest wall, and between the lung and the hilum, and between the lung and between the lobes itself. Next. And again, you can see how difficult it is. We try to release the lung tissue from the chest wall because bleeding everywhere actually, and the tissue was friable. Next. Again, another slide to show you how difficult it is. We may need to remove part of it. There's bleeding here and there. And finally, before I close up, these are the technique that we use to give intercostal block from the 3rd to 6th intercostal space. Even for this kind of surgery, to reduce the pain to the patient post-operatively. So these are the effect. So at the end of the day, we didn't manage to fully perform video assisted thoracoscopic surgery for this patient. So end up convert this procedure to open thoracotomy from the 3.5 centimeter to 6 centimeter. As you can see, there's a lot of adhesion, a lot of bleeding. There's a lot of trauma to the tissue. The tissue is so friable. Next. So these are the lobes that were delivered. The right upper lobe, a bit of middle lobe from the surgery. Thank you very much.
Right, thank you so much, Dato Faizi. All right. As you can see, this is the intraoperative findings. It was severely adhered between the right upper lobe and also the areas of the fungal wall to the thoracic cavities. Even though adhesiolysis is done, extensive adhesiolysis done during VATS, we have to convert into a normal thoracotomy. The fungal ball extends into the medial part of the right middle lobe, and then with this incomplete fissure as seen at the adhesiolysis. So we have to take part of the lower lobe, middle lobe as well. Part of the middle lobe as well, and this is a very, very friable tissues and easily bled. But however, we have managed well during the operation. With the help of our cardiothoracic anesthesiologist, the patient went back to the ICU. Can we next slide, please? All right, back to Dr. Ng. Right, we have done the surgery, and during surgery, all countermeasures have been done. What are the things post-operative planning, anticipate, and management for this patient?
Thank you, Mr. Isham. So now that the patient is, the operation is done, first of all, we need to ascertain the post-operative disposition of the patient. Because the patient is still intubated, I would like to put the patient in ICU first. let her stabilize. Once she is more stable and she's extubated, then we can progress to down triage her to the ward. At the same time, post-operatively, we need to anticipate some of the potential complications that can happen. I would divide my complications into immediate as well as delay complications. The immediate complications will be bleeding, air leak, as well as stump blowout from the site of lobectomy that we have performed. And also for the delayed complications, there will be sepsis, wound breakdown, and also the possibility of recurrent aspergilloma.
All right, this is the common complications and also that we anticipate, and all the management has been managed well post-operatively in ICU. Next slide, please. So the progress is well, very good. No immediate post-op complications. There's no bleeding. There's no air leaks as a stump blowout and any trauma to the other lungs. Patient only intubated for only 2 days post-operatively, and then we managed to de-escalate and then extubate the patient after 2 days. And this is showing that there's no sepsis. There's no indication for the patient to extend the intubation. Antifungal and antibacterial, antifungal and antibiotics works well. She has stable hemodynamic and gone back to the ward well, and she has a very good effort for spirometry. The wound is superbly clean, and with I think 7 days after the surgery and after good physiotherapy, patient has managed very well in the wards. Prior to discharge, we did a chest X-ray. This is some minimal pneumothorax, right pneumothorax, so minimal, just minimal that we can manage conservatively for her. And so we have done, alhamdulillah, patient have gone back, and things that we anticipate, next slide, things that we anticipate can be confirmed in the histological findings. For this, I would like to call upon Professor Rina Rahayu, our consultant in pathologist, to present about the histological findings. To you, Prof.
Okay, thank you, Dr. Ishamuddin. Assalamualaikum. Right, okay, so before I proceed to the next slide, Dr. Ng, may I ask you, I noticed that in the early investigation, the fungal culture and sensitivity was negative, but the Aspergillus antigen was positive. So what would be your next step of action to confirm this finding in terms of laboratory investigation?
Thank you, Prof. So in terms of next step, we would like to send the intraoperative cultures and sensitivity from the lung tissue that we have resected. First for fungal culture and sensitivity, HPE, as well as to confirm again for TB for the patient.
Right, okay. So we received the histopathology tissue. Can you move to the next slide, please? So this is what we saw on H&E, on histopathology. We saw fungal infective organism, which demonstrates acute angle hyphae. Next slide, please. Okay, so on higher magnification, the fungal hyphae demonstrated septate bodies. Okay, so these two are quite a distinguishing feature, characteristic feature for this organism. Okay, next slide, please. So to confirm those hyphae or infective organisms were fungal, we did special stains, which is periodic acid shift and Grocod's methenamine silver, which highlights the polysaccharide wall of the fungal. Okay, next slide, please. Okay, so the differential diagnosis would be mucormycosis instead of, this would be the major differential diagnosis, right? The other differential diagnosis will also be candida, but because based on the morphology, mucormycosis comes very close to the main diagnosis. Okay, so but in mucormycosis, we see broad and non-septate hyphae with greater angle of branching. Okay, so next slide, please. So based on the acute angle branching and the septate bodies that we saw earlier on, so we sign out this case as fungal infection consistent with aspergillosis. Okay, thank you.
Right, thank you, Prof. Rina. So we have the diagnosis confirmed by histopathology, and it is consistent with invasive aspergillosis. All right. To benefit of all medical students, this is a case of invasive aspergillosis, and how to manage it is starting from medical management first. And if it's the deemed complications, such as this patient, bleeding is a problem, right? And then that bleeding a problem with concurrent medical management, we have to do some surgery to save his life, to save her life. But nevertheless, we have to start from medical management first. I would like to call upon Dr. Nick Noatika to present a bit of her point about medical management for invasive aspergillosis. So you, Dr. Noatika.
Okay, thank you, Mr. Hisham. So the medical management in terms of invasive aspergillosis, it's actually have many options. So one is actually voriconazole, the other one is M4B, or we can actually choose itraconazole. But Dr. Juin already mentioned about M4B before this, right? So the options would be, the first line would be voriconazole, okay? So how many months or how many weeks you need to continue? So it should be at least 6 to 12 weeks, yeah, depending on the recovery or depending on the imaging and also in clinical recovery, okay? That is the medical management for invasive aspergillosis.
All right. Is this the first choice?
The first choice would be voriconazole.
The first choice would be voriconazole.
Yes, but in our patients, we put her on itraconazole.
Itraconazole. Okay, all right. Okay, thank you so much, Dr. Natika. We start off with this anti-aspergillosis treatment. The patient has gone well on this itraconazole. And I think it was on Rosafin. Later on, probably we put on Tinum, if I'm mistaken. And she had wonderfully well on the antifungal and also antibiotics that we are given. All right. She has gone well, and she was discharged with some oral medication. I think she was discharged with tablet augmentin, if I'm not mistaken. But he was well during the follow-up. Also, he was well, and what we can learn from this case is a take-home message for this case is, number one, is importance of MDT. For the benefit of medical student, MDT is multidisciplinary team, which is we gather a team with a different disciplinary and specialty. For instance, for this patient, the management is comprised of cardiothoracic, respiratory team, ONG, radiology, and also pathology. Not to forget that the intensivist is also involved. So that team, we gather together, and also we discuss about what is the best for this patient. As I said before, the best is one of the best management for this patient is to prolong the pregnancy as the input by the ONG. But at 26 week, we have to deliver the baby as soon as possible. So there's the importance of MDT for all complex patients, such as this case. And number two is the management of hemoptysis. The management of hemoptysis, as Prof. Andrea said before, there's a few differential diagnosis of hemoptysis. It's going to be infection, it can be cancer. As to confirm what is the diagnosis of this patient. If it's like this patient, it is invasive aspergillosis, one of the cause. So we start off antifungal. But if hemoptysis persists with hemodynamic instability, then the management will be surgery for this patient. It's not. It's the same as other. It's same as other diagnosis. When the patient have massive hemostasis deemed unstable, the management for this patient is one of it is surgery. And of course, there's a few other modalities such as done by interventional radiologists, that is embolization. The timing for surgery, in fact, just like Dato Faizi said before, the best for fungal or in fact stable invasive aspergillosis, we can complete the antibiotics or complete antifungal. We can do as elective surgery or semi-emergency surgery, but this one is emergency surgery because patient has been recurrent hemoptysis deemed unstable hemodynamically. So the timing of surgery is important with sufficient antifungal antibiotics coverage during prior to operation. This is another thing that really important. And the type of surgery, of course, this is an emergency surgery. We can do VATS, but if deemed difficult, especially for this patient, very dense adhesion that we do not want to prolong, there is a high chance they're going to be bleed with a lot of complications intra-op. We correctly convert into open, and we bring out as much as possible all the affected tissue. All right. So all in all for this, after all hard work from all discipline, we have come to about a happy family. Patient survived. Can you get the next case? Patient survived. This is the photo by the husband. Thank you so much for the husband for sharing this photo. We have a happy family. Patients alive, and patients have a healthy baby. Okay, this is a result of our hard work. From all the discipline that is involved. I would like to congratulate everyone who is involved for this patient to make this case a success. And I think with that, thank you so much for everybody who attend this meeting, attend this CPC. A pleasure for all of for us to present this wonderful case and to present this wonderful photo for all to learn. And I think I would like to call any questions from the floor. Any questions from the floor that any dying questions that you want to ask any of the panels? Can I open up questions from the floor? Going once, going twice, tak ada. All right, probably straightforward, very complex but straightforward case. Yes, Prof. Andrea? Right, very straightforward case. And happy for us to help this patient, and very enlightened for us to see patient's smiling face with this photo. Okay, all right. Thank you so much again for attending. I would like to pass the baton to the organizer for the CPC. For the Kahoot session for medical student. Right, for that, thank you so much, everybody. Thank you so much for the panels.
Thank you, Dr. Hisham. Thank you very much.
Thank you so much.
Thank you.
Well done, Dr.
Thank you, Mr. Hisham. Thank you, Prof.
Thank you, Mr. Hisham. Thank you.